Dear participants, my name is Gavin McDonough, and I'm the Educational Action Supporting Officer at ERN-EuroBloodNet, the European Reference Network for Rare Hematological Diseases. And it is my great pleasure to welcome you to the ERN-EuroBloodNet Topic on Focus on Constitutional Thrombocytopenia, which is an accredited program for a European online educational program targeting health professionals organized by the ERN-EuroBloodNet and in partnership with the CRPP, which is the French Reference Center for Inherited Platelet Disorders, and the Filière MHEMO, which is the French Constitutional Bleeding Disorders Network. This program consists of a cycle of webinars focused on constitutional thrombocytopenia that was developed in collaboration with three experts that are present tonight, Professor Marie-Christine Alessi and Dr. Paul Saultier from Assistance Publique-Hôpitaux de Marseille, which is also a member of the ERN, and Dr. Mathieu Fiore from CHU Bordeaux. It's important to note that this is the last of the webinar in the series, and it has been a great honor to host this webinar series with such wonderful coordinators. Before we start, let me share some home rules. Please note that the session is being recorded and will be uploaded in the EBN e-learning environment. If you do not wish to appear, please turn your camera off and change your name on the platform. Also, be kindly informed that your microphone is muted. If you have any questions about the presentation, please write them in the chat, and they will be addressed during the Q&A session at the end of the webinar. And with that great honor, I would like to introduce today's webinar, which is on constitutional thrombocytopenia, platelet transfusion, and other hemostatic therapies in inherited thrombocytopenia. And today's speakers are Professor Andreas Greinacher and Dr. Carlo Zaninetti. Professor Andreas Greinacher specialized in transfusion medicine, immunohematology, and hemostasis, and has been a full professor and head of the Department of Transfusion Medicine and Thrombosis and Hemostasis Service at the University Greifswald, Germany, until 2024, where he is now associated senior professor. His research interests are hereditary and immune-mediated thrombocytopenias, especially hairpin-induced thrombocytopenia, and application of biophysics to understand molecular mechanisms of antigenicity of endogenous proteins. And Dr. Carlo Zaninetti graduated in medicine and surgery and specialized in internal medicine at the University of Pavia, Italy. He currently works as physician and researcher at the Department of Transfusion Medicine at the same university, Greifswald in Germany, under the mentorship of Professor Andreas Greinacher. His research focus are clinical and diagnostic aspects of inherited platelet disorders. And with that, I welcome both of our speakers tonight. Thank you very much. The floor is all yours.
Yeah, Gavin, thank you very much for the kind introduction. And I welcome all the participants, and I see from the list of participants that many colleagues and friends I know very well are in the audience. And today, Carlo and myself will try to give you a clinical pathological approach, how to manage patients who suffer from inherited platelet disorders. This means we try to focus on some of the clinical aspects and will address a few of the molecular aspects, but the focus of this webinar is more management than pathogenesis. Carlo has nothing to disclose. I have several disclosures, but they are not related to the topic of this webinar today, and they don't influence any of what I'm presenting today. The structure of the talk is four major topics. First, a brief overview on inherited platelet disorders and the associated bleeding risk. Then we will speak a bit about an important part, which is usually not the main field of the ones who take care for patients with hereditary platelet disorders. These are the surgical interventions. Quite a large part of the talk will be dedicated to medical interventions ranging from transfusion to antifibrinolytics to the TPO receptor agonists. And the last part is not very spectacular and often neglected, but in our opinion and in my opinion, highly relevant. This is counseling of the patient and the family doctors of the little details which might be quite important to maintain a quality of life in patients. As all of you know in this audience, there are many inherited platelet disorders. In more than 60 of them, we now know also the genetic background. Many of them are associated with a low platelet count, while others are primarily platelet function disorders, and in some of them it's a combination of both. So a highly diverse field and underlying cause why platelets might be disturbed. A bit trivial, but the basis for this talk is all patients with inherited platelet disorders have an increased bleeding risk. This trivial statement is relatively clear, but the underlying mechanisms why patients bleed are highly complex and differ widely among patients with different forms of inherited platelet disorders, and this may have quite an impact on how to treat them. As I mentioned before, platelet numbers are often reduced in many of the inherited platelet disorders, but, and this is an important theme and sometimes not very well known, that the clot stability is much more impaired in patients with thrombocytopenia than one would deduct from the pure platelet number. So it's the clot stability is reduced, and this is one of the reasons why these patients bleed. This means platelet function has obviously an important role on clot stability, but this is highly variable and highly different among different inherited platelet disorders, and this may also affect the treatment approach.
The bleeding phenotype, and particularly the bleeding severity, is not the same in all patients with inherited platelet disorders. As shown by this study that validated the use of the ISTH bleeding assessment tool in patients with inherited platelet disorders, the vast majority of patients with inherited platelet function disorders display a clinically relevant bleeding diathesis, whereas only a minority of patients with only thrombocytopenia display clinical relevant bleeding symptoms. Importantly, the past bleeding history of the patients, taking into account through the bleeding score the entire life, predicts the occurrence of future bleeding in all patients, regardless of the inherited platelet disorder subtype. This concept has been very well shown also by two other studies that investigated the outcome of pregnancy in women with inherited platelet disorders, and the mothers who experienced excessive bleeding at delivery were those with platelet count lower than 50,000 per microliter in the group of inherited thrombocytopenia, and those with a severe defect of platelet function in the group of inherited platelet function disorders, here mostly Glanzmann thrombasthenia. And again, in both groups, the bleeding tendency evaluated with the bleeding score at baseline correlated with the occurrence of bleeding complication at delivery. As regards another important hemostatic challenge, the surgery, a very large retrospective study investigated the outcome of more than 800 surgical interventions performed in patients with 25 different disorders. And it showed that the overall frequency of surgical bleeding is 20%, 1 in 5 procedures. But this frequency was twice as high in patients with inherited platelet function disorders compared with patients with inherited thrombocytopenia. Moreover, cardiovascular and urological procedures were associated with a higher frequency of bleeding, as well as the female gender, but limited to the group of inherited platelet function disorders, whereas thrombocytopenic patients had a higher risk when the age was over 70 and the platelet count lower than 70,000 per microliter. And the other very important message of this study was that it is deeply possible to reduce the occurrence of bleeding at surgery when using appropriate anti-hemorrhagic prophylactic treatments.
And this will now be addressed for the next part of this webinar. And we start with surgical treatments to stop bleeding. As discussed before, all patients with inherited platelet disorders have an increased bleeding risk, which often does not correlate to the platelet number. And it is important before elective interventions to inform the surgeon and the anesthetist that the platelet count alone is not predictive for the bleeding risk of the patient. And for certain, careful surgical closure of small vessels is one of the most important measures to prevent major bleeding complications in patients undergoing surgery. Now, the surgical intervention by itself again causes tissue trauma and can increase the bleeding risk. And therefore, especially in trauma patients, new possibilities offered by the interventional radiologist should be taken into account by managing these patients, as arterial embolization can reduce the bleeding and stop the bleeding without the surgeon inducing additional tissue trauma by his intervention. That in sites in which one can easily access, like epistaxis, nasal packing, and compression, are appropriate interventions is obvious, like suturing after tooth extraction, application of sponges and gauzes, soap with tranexamic acid or other pro-hemostatic agents, and mouthwash with tranexamic acid is also found in most recommendations related management of these patients. Beside the surgical interventions, another invasive intervention is blood transfusion. And here I would like to raise your awareness that blood transfusion is not only transfusion of platelet concentrates, but probably much more important, transfusion of red cell concentrates in the bleeding patient. There's uniform agreement that in patients who are at risk to develop HLA or other alloantibodies, only leukodepleted blood products should be used. My theme today is to provide you some information that platelet transfusion should be avoided whenever possible. On the one hand, platelet transfusion can cause immunization. On the other hand, platelet transfusion is probably not the most effective measure to treat these patients, and this concept is not very widely discussed at the moment. On the other hand, very different to what is highlighted by patient blood management initiatives, be liberal with red cell transfusions in case of active bleeding. And this is quite against the usual recommendations where a careful non-liberal transfusion approaches and strategies are recommended. And why is this? And this is a nice study from Mo Blatchman 30 years ago. He showed in a rabbit model that the hematocrit nicely correlates with the bleeding time. And what is the pathophysiological concept behind? This is the graph of a small artery, and in any stream there's shear stress, and particles organize themselves by pure biophysical reasons according to their size. The large particles are in the middle, And as smaller the particles are, as more they are shifted towards the side of to the walls, which in case of platelet function makes a lot of sense, because there they can recognize disturbed vessels and can start adhering and functioning. If the patient is anemic, simply the number of red cells is not large enough for this biophysical effect, and platelets are no longer pushed towards the vessel side and can therefore not function as good as they can if there are more red cells. And all of you know that many inherited platelet disorders are associated with enlarged platelets. Now, the effect that the smaller particles are pressed and marginated to the side of the stream do not account because of the larger size of platelets. And if this is combined with anemia, both effects add together to an increased bleeding risk. I would like to draw your attention to the beautiful work from John Weissel from Philadelphia, who nicely showed and the biophysical properties by which red cells contribute to the strength of clot formation. And that's an electron photomicrograph from one of his review articles showing that at the outer layer of the clot, platelets and fibrinogen and fibrin is formed, while the inner core of the clot is primarily formed by red cells, which, as you see on the right-hand side, change their shape and show a cobblestone appearance and are tightly packed. Red cells can contribute many more functions to clot formations, and those of you who are interested in this special aspect are referred to a really good review of Rita Lassila and John Weissel, which appeared last year in the Journal of Thrombosis and Hemostasis. Beside these more theoretical considerations, there is at least one great study in human volunteers. This study is also more than 20 years old, but one of the best data available for the concept. 29 healthy volunteers were liberally depleted, either for red cells by obtaining 2 units of whole blood from them, or by platelet apheresis, decreasing the platelet count by about 30%. And then the bleeding time was measured at that time with the cutaneous bleeding time in a more or less standardized approach. What became very obvious, reduction of the hematocrit by 15% increases the bleeding time substantially, while reduction of the platelet count by even 30% has minimal effects on the bleeding time, again highlighting in an in vivo human model that the hematocrit contributes substantially to the bleeding risk of the patient. Now, not in inherited platelet disorders, but in hyperproliferative thrombocytopenia, the PLADO trial in the transfusion medicine world, a very important landmark study, also provided information on the association of the hematocrit and the bleeding risk. This is a sub-analysis of the PLADO trial in which patients were assessed for the percent of days with grade 3 or 4 WHO bleeding, so clinically relevant severe bleeding complications, independency of the hematocrit. And again, it is obvious, once the hematocrit is below 25, the bleeding risk substantially increases, while there is a relatively minor effect above the hematocrit of 30%. Again, to avoid misunderstandings, these are not IPD patients, but hyperproliferative thrombocytopenia, but it makes the point that the hematocrit is relevant. The take-home message for today is red cells are important modulators of bleeding in platelet disorders and probably underestimated in their role. Clinicians taking care for patients who are bleeding, actively bleeding, either during major interventions or after trauma, should aim for a hematocrit of 30% to support the hemostatic capacities in these patients. If the patient still bleeds, the surgical and hematocrit options have all been taken, then platelet concentrates are the next transfusion blood product of choice. Again, agreement that only leukodepleted platelet concentrates should be used in all patients because they reduce the risk of HLA or HPA alloimmunization substantially. They do not eliminate this risk, they reduce it. For those who are working in environments and in medical settings where often relatives are asked to donate the blood product, should be advised that platelet concentrates donated by first-degree relatives need to be irradiated to prevent transfusion-associated graft versus host disease. The shared HLA haplotypes in first-degree relatives with the patient can cause that the immune system of the patient does not recognize the T lymphocytes and the blood product as foreign, but the T lymphocytes and the blood product recognize the patient environment as foreign, and then they attack the bone marrow of the patient. The same accounts for immunodeficient patients like viscod-altered patients. Here I summarize my opinion as a transfusion medicine and platelet expert. And I'm fully aware that I raise some topics here which might cause debate and discussion. My recommendation is to use random platelet concentrates rather than HLA-matched platelet concentrates in non-immunized patients with hereditary platelet disorders. The rationale for this is that it is often difficult to provide HLA-identical platelet concentrates. So the transfusion expert uses HLA-similar, compatible platelet concentrates, but this increases the risk to immunize against relatively HLA-similar antigens, which would be otherwise compatible, and reduce the option for the patient to be treated when he is really immunized. HLA-matched platelet concentrates should only be used in case of real alloimmunization. In nearly all reviews, there's a statement that apheresis platelet concentrates should be used in all patients with IPD. I object against this recommendation. In my opinion, pooled platelet concentrates makes more sense. Why is this? In an apheresis platelet concentrate, all platelets are from one donor, while pooled platelet concentrates consists of platelets of 4 to 5 different donors, which results in a much lower dose of the single HLA antigen, which reduces the risk of alloimmunization by a pure dose effect. And again, a strong note against using platelet concentrates from first-degree relatives. And this is because also patients with IPD can develop other diseases which may require stem cell transplantation in the future. And using a first-degree relative can cause immunization against minor transplantation-relevant antigens, causing then later trouble for finding a compatible family stem cell donor. In red cell serology, it is standard to make antibody screen and cross-match before transfusion, but this is not standard in platelet transfusions. But our recommendation is to use this as a standard measure in patients with severe platelet disorders, especially before planned interventions, to screen them for HLA and anti-HPA antibodies. If they are negative, random pool platelet concentrates can be used. However, if antibodies are positive, then matched apheresis platelet concentrates are needed. After transfusion, the platelet count increment should be monitored. If there's insufficient increase, the circle of testing and selecting compatible platelet donors then continues. Immunization against platelet alloantigens, which are epitopes exposed, blood groups exposed on different platelet glycoproteins, are a relatively minor problem in patients with inherited platelet disorders. The big problem are isoantibodies against missing proteins. These are polyclonal antibodies against multiple epitopes developed by the recipient against the missing protein, which is for certain exposed on the platelets of the platelet donor. Patients with Glanzmann thrombocytopenia and Bernard-Saultier syndrome are the ones which are at the highest risk. And once these isoantibodies have been developed, they will make effective platelet transfusion nearly impossible and also can cause in women severe fetal-maternal incompatibilities. For assessing the risk, it is really helpful to see whether there is still minor exposure of the glycoprotein, as exemplified here in Glanzmann type 1 and type 2. A Glanzmann type 1 patient who is not expressing the protein at all has a high risk for developing isoantibodies after transfusion, while a patient with Glanzmann thrombocytopenia type 2 who still is exposing some of the glycoproteins on platelets, even in small numbers, has a negligible risk for immunization because the immune system knows the antigen as endogenous protein and usually does not immunize against this. A landmark paper on inherited platelet disorders has been provided in 2019 by Wolfgang Bergmeyer's group. It's a busy slide, and I guide you through. They used thrombocytopenic mice, which they made thrombocytopenic using an antibody, and transfused them 5 to 10 to 7 platelets per ml. And this nicely lowered the bleeding time and normalized the bleeding time. And then they used a mouse model with severe platelet function defect using double as many platelets, 1 times 10 to the 8 per milliliter, only marginally reduced the bleeding time. They had to use 6 times as many platelets as in those only thrombocytopenic mice to achieve more or less normalization of the bleeding time. And this is also seen in different other mouse models. Here in a Glanzmann-like mouse model, in which transfusion of platelets barely had any effect on the bleeding time, while in a Bernard-Saultier-like mouse model, the bleeding time normalized. So how can this be explained? In the Bernard-Saultier-like mouse model, it is necessary to augment with the transfused platelets the layer of platelets on the von Willebrand factor. And then the Bernard-Saultier platelets can clot and form a clot on top of them, while the Glanzmann platelets cannot form a clot at all due to the lack of the fibrinogen receptor. And the explanation for this is in a clot, and these are clots taken from these mice platelets, it is not the transfused healthy platelets which work with each other. It's always a mixture of the impaired platelets and the healthy platelets, which work together, but if half of the platelets don't function, the entire clot is non-stable. Another example, that the reason for the platelet disorder, although phenotypically very similar, depends a lot on the effect of platelet transfusion, is a defect in thromboxane synthesis. If this is impaired and normal platelets are transfused, which can produce thromboxane, the released thromboxane can bind to the intact thromboxane receptor on the patient's endogenous platelets, and they get activated and function. If, however, on the other hand, the thromboxane receptor is defect, the transfused platelets, when they produce thromboxane, do not recruit the endogenous platelets of the patient, and the effect is much smaller. So it really depends on the underlying pathomechanism of the platelet disorder, whether platelet transfusion is sufficient and helpful or not. But in the majority of patients, platelet transfusions are much less effective than assumed from the data we have obtained from patients with hyperproliferative thrombocytopenia.
But not only the structure, as we have just heard, is alterated in inherited platelet disorders. Also, the stability of the clot is impaired. And the final consequence of this is that the plasminogen and plasmin can easier enter the clot and dissolve it. For example, a large group of inherited thrombocytopenia display a cytoskeleton defect. Typical example is MYH9-related disease, probably the most frequent forms of inherited thrombocytopenia worldwide. And this give us the opportunity to talk about the antifibrinolytics treatment. Antifibrinolytics are one of the most often used medications in patients with inherited platelet disorders and inherited thrombocytopenias other than platelet transfusion. And their efficacy, which is empirically very well known, suffer from a poor level of evidence. These experiments have been conducted in mice and a human model of MYH9-related disease. As said before, the most frequent form of inherited thrombocytopenia. In these disorders, the cytoskeleton is affected, and as a consequence, it cannot exert enough force to drive the process of clot retraction. Clot retraction happens normally after clot formation, and you can easily see this process in this slide. If you look at this very small metal bar we used in the setting as a sensor, when the clot retraction occurs normally, the bar is pulled upwards, whereas in the affected mice on the right, the bars remain at the bottom of the cuvette. We then reproduce it, mimic the physiological lysis using plasminogen activator, and then increasing concentrations of tranexamic acid up to a therapeutical concentration. And doing this, we were able to observe an improvement of the retractional performance of these clots. In the same disease, we had also the chance to investigate the thrombi formation under flow. And what we observed, again, by reproducing the physiological lysis using plasminogen activator, was that the content of fibrin was lower. When we then block the lysis with tranexamic acid, interestingly, the residual fibrins, which is in this picture in magenta, was comparable with that we observed in the control. And the particular sensitivity of these clots to the physiological lysis is very well shown also by the experiment conducted in rotational thromboelastometry. Please look at the red curves. that clearly indicates that the onset of the lysis occurs earlier in the patient with respect to control. Desmopressin is another drug to take into account. Everyone knows that these drugs promotes the release of von Willebrand factor from the endothelial cells. This is the reason why this is indicated and used in mild hemophilia and type 1 von Willebrand disease. But there are many reports since many years that suggested that desmopressin can also have a positive impact on the hemostasis also in patients with inherited platelet disorders or thrombocytopenia. And in this case report published by Andreas Greinacher in 1993, the efficacy of desmopressin in reducing the bleeding time in a patient with Bernard-Saultier syndrome was described. Interestingly, after the infusion, the bleeding time reduced as expected, and the von Willebrand factor level increases as expected. But later, despite von Willebrand factor remain high, the bleeding tendency of the patients increased again. And this strongly suggested that the mechanism below the effect of desmopressin should be independent from the von Willebrand factor. And interestingly, 20 years later, a possible explanation of this phenomenon was provided by the group of Lorenzo Alberio, who showed that after infusion of desmopressin in patients with platelet function defect, the production of procoagulant platelets increased. And these platelets, which are kind of super platelets at the site of injury, probably are able to compensate the dysfunctional platelets in these patients.
Yeah, and these coat platelets Carlo mentioned, they propagate fiber information on the platelet surface, and this is exactly the same mechanism which recombinant activated factor 7 is using, and is approved since many years for improving hemostasis in Glanzmann patients. It has anecdotally been used in Bernard-Saultier patients. It might be used in patients with other inherited platelet disorders when other interventions are not successful to stop bleeding. The very new development, which opens a new perspective for treatment of especially of Glanzmann patients, is a bispecific antibody, which is binding to a platelet protein TLT1. But this is only used as an anchor for this bispecific antibody. The mode of action is that this antibody is directing endogenous activated factor 7 to the surface of platelets and thereby triggering increased fibrin formation. And this increased fibrin formation on the platelet surface even induces, and in the aggregometer, fibrin-dependent pseudo-aggregation of these platelets, reflecting in vitro what most likely happens in vivo. The important aspect that this drug is probably the first drug which can be used for primary prophylaxis in severe Glanzmann patients. As it is an antibody, it can be applied subcutaneously. It is feasible to use it in self-application every 2 weeks. The ongoing phase 1 and 2 trials are very interesting. The last week ASH meeting, the next results had been presented. It dose-dependently increases endogenous total factor 7 and factor 7A activity by stabilizing them. It can be given every 2 weeks. And if this drug proves in the ongoing clinical studies to be successful and without major adverse effects, it might change treatment of Glanzmann patients considerably.
A promising alternative to platelet transfusion to prepare patients with inherited thrombocytopenia to elective surgery is represented by thrombopoietin receptor agonists. These drugs are indicated and used in immune thrombocytopenia, bone marrow aplasia, and hepatitis C associated thrombocytopenia. In particular, two drugs, eltrombopag and romiplostin, have been very well studied over the last 15 years in patients with inherited thrombocytopenias. In this small trial, a course of eltrombopag was given to patients with inherited platelet disorders due to MYH9-related disease and was effective to transiently increase the platelet count in the vast majority of the patients treated. And what you are now observing is the results. This was a patient with MYH9-related thrombocytopenia and severe thrombocytopenia at baseline with mucocutaneous spontaneous bleeding, who was prepared to orthopedic procedures using eltrombopag starting 20 days before the scheduled date of surgery. The platelet count increased progressively, more rapidly after 10 days. The patients experienced the disappearance of the bleeding symptoms, reached a safe platelet count at surgery, underwent surgery without bleeding complication, and not less importantly, could receive a regular antithrombotic prophylaxis. This is a very important point because we have to keep in mind that these patients are not protected against the post-surgical thrombotic risk. In a second trial, 10 years later, the efficacy of eltrombopag was confirmed in MYH9-related disease, but also demonstrated in monoallelic Bernard-Soulier syndrome, one of the other frequent forms of inherited thrombocytopenia in Europe, and also, albeit to a lesser extent of the magnitude of the response in patients with ANKRD26-related thrombocytopenia and Wiskott-Aldrich syndrome or X-linked thrombocytopenia. Even in these patients, the observed average increase of platelet count let us conclude that this drug could be effective in strongly reducing the use of platelet transfusion for even for this patient for most surgical procedures. 4 patients with 3 different disorders have also been treating long-term with eltrombopag up to 16 weeks with the goal to reduce the spontaneous bleedings. And this goal was achieved with an improvement of the self-reported quality of life of the patient, including the symptoms of fatigue, which is typically reported by patients with chronic thrombocytopenias, even beyond the hereditary disorders.
I would like now to switch gears to the less spectacular but highly relevant aspects of counseling the patient and the family doctor, how lifestyle impacts the risk for bleeding. As mentioned before, anemia can modulate the bleeding risk and increase the bleeding risk. And preventing iron deficiency anemia is the most important treatment aim in inherited platelet disorders, not only for the bleeding risk, but for all the other adverse effects iron deficiency is associated with. And a very recent paper in Blood Advances assessing treatment of iron deficiency anemia in a large population study of 13,000 patients showed that even after 3 years, only in 40% of patients, iron deficiency anemia was resolved. And also in our experience, the majority of women at childbearing age with iron deficiency, with inherited platelet disorders suffer mostly from iron deficiency anemia. Monitoring of ferritin and supplementation of iron are basic measures in these patients. And instead of starting not very effective oral treatment, initial treatment with IV iron, especially in women, is filling up the iron stores. And then oral iron supplementation may support maintenance treatment, but this is again often insufficient, and women at childbearing age require regular iron substitution. Another aspect which should not be neglected is the risk of menorrhagia in young girls. And these girls with severe platelet function disorders should be linked to a gynecologist even before puberty, because with onset of the menarche, the bleeding can be really dramatic in some of them. And if they are then confronted together with their first menses with the gynecologist and not knowing the procedure, not knowing the gynecologist, this can be very traumatic for the girl and for the family. Many more frequent or most frequent causes of bleeding in IPD patients modulated by the lifestyle are drugs interfering with platelet function or natural medicine and herbs. Everyone knows that aspirin and the NSAIDs and the ADP receptors inhibit. That serotonin reuptake inhibitors cause an increased bleeding risk is less well known. And this is relevant because many of patients with inherited platelet disorders suffer from fatigue. And this is not too rarely treated with antidepressants. Other antidepressants and psychopharmaca have also platelet disorder or platelet impairment of platelet function, especially for the elderly patients with inherited platelet disorders. It must be taken into account that sartans, often used to treat hypertension, impair GP6 activation and can induce the bleeding risk, and statins reduce platelet functions, especially in MYH9 disorders who have hypercholesterolemia. Quite often statins are required, but this can modulate the bleeding risk of the patient, and anticonvulsants can increase the bleeding risk substantially, not speaking about all the herbs and alternative medicines. Especially for this group, the patient needs to be educated to avoid taking this type of food additives, or if they start bleeding, they should try to remember whether it is associated with any intake of alternative medicines.
A typically neglected complication of hypothyroidism is an acquired form of von Willebrand syndrome. The associated bleeding symptoms are usually mild, but they can sum to the pre-existing bleeding tendency of patients with inherited platelet disorders. For this reason, the control and the proper treatment of dysfunction of thyroid is very important and should be recommended in patients with inherited platelet disorders. Similarly, maintaining a good oral hygiene is also to be strongly recommended, thus reducing the risk of bleeding complication due to surgical procedures, but also to reduce the occurrence of gum bleeding spontaneously, for example, in case of parodontitis. Patients with bleeding tendencies are typically advised to avoid contact sport. This is totally understandable and correct, but one has to be aware that also a regular sport activity should be recommended, not obviously with proper protection. And in this case, particularly for children, it is important to educate also the parents who have to set the example, for example, wearing the helmet by cycling. And also the UV ray exposure is a topic because it can trigger bleeding manifestation, typically cutaneous, and in particular in patients with severe thrombocytopenia or a severe platelet defect should be recommended to avoid prolonged sunbaths and to defend themselves properly from the sun. We finally just mentioned two therapeutical measures that theoretically could cure each patient with inherited platelet disorders, but they represent an option only for a very small group of patients. Hematopoietic stem cell transplantation is the therapy of choice in patients with severe Wiskott-Aldrich syndrome, with thrombocytopenia, immunodeficiency, autoimmunity, and for very rare forms of inherited thrombocytopenia, which are associated with the development of a very severe bone marrow aplasia during childhood. And lastly, gene therapy as alternative to stem cell transplantation has been so far investigated and used in 25 children with Wiskott-Aldrich syndrome. The results are encouraging, and it probably represents an alternative to stem cell transplantation, in particular for adult patients.
Yeah, to sum up, Carlo and I aimed to present you a clinical pathological approach to manage patients with inherited platelet disorders. And the main points we want to make is that all patients with inherited platelet disorders have an increased bleeding risk, but the mechanisms differ widely. And this is why it's so important to better understand the molecular causes. Clot stability is much more impaired than in patients with thrombocytopenia only and otherwise normal platelet function. And it is really important to explain this to the other colleagues in the treatment team, especially before surgery, that they undertake all efforts of surgical measures to stop bleeding. And especially in trauma, the advantage of interventional radiology should be used to avoid additional tissue trauma by the surgical intervention. Most important is to prevent and to treat anemia. We try to provide you with the evidence why the hematocrit is such a modifier of the bleeding symptoms in these patients. And one should use really all options to prevent platelet transfusions, to avoid alloimmunization, especially against HLA antigens, to leave this option for the patient when it is really needed in an emergency situation. Finally, not highly scientific, but extremely important, is counseling of the patient and the family physician, because often the little details are highly relevant for prevention of severe bleeding or minor bleeding, which has a major impact on the quality of life of the patient. And before I end, we would like to thank all the collaborators with whom we worked on different aspects of inherited platelet disorders during the previous years. And I know that several of you are in the audience, and we thank you for your attention, and we are happy to take any questions.
Great. Thank you so much for your beautiful presentation. Very concise and very clear. We do have a couple questions in the chat. I can read them out loud and then you'll have a chance to answer. Is it probable that the HMB-001 antibody can also be effective in other types of IPD different from Glanzmann disease?
That's now speculation. It might be that like recombinant 7A is probably also effective in some other forms of IPD. I think once the drug is available, it will be used in different types of IPDs, and then one can see whether it's effective. It's probably not effective in all, depending on the underlying mechanisms.
If I can add a comment, the probable advantage of this drug is that it will exploit the endogenous activator factor 7 that's bringing in proximity to platelets and then reducing the associated thrombotic risk of recombinant factor 7, which is sometimes used in these patients.
Great, thank you very much for those answers. We have another additional question. What about the prophylactic use of tranexamic acid? When to start orally, and how is the dose prior to elective surgery? Also, how to continue intravenously during or after surgery?
Recommend to use the standard dose. If one is using oral tranexamic acid, which is especially helpful to reduce bleeding during menorrhagia, it's between 0.5 to 1 gram 3 times per day orally. And during surgery, the standard dose used also for major orthopedic or cardiovascular surgery are the appropriate doses, usually given 1 gram before surgery and then 1 gram over the next 2 to 4 hours. In our own praxis, we tend to continue then tranexamic acid for at least 5 to 7 days after surgery.
Great. Thank you so much for this question and for the answer. We have another question from one of our coordinators that's present tonight, Mathieu Fiore, Dr. Mathieu Fiore. Should we always use HLA matched platelet concentrates in immunized patients without platelet refractoriness in IPDs?
No, it becomes really really specific to one of the transfusion problems, whether if one sees some HLA antibodies by the Luminix method without obvious biological effects. That's a bit an unresolved question. I would try to use HLA matched platelets in these situations to avoid boosting of the already existing immune response, to avoid formation of high avidity antibodies.
Sorry. We also have an additional comment. There's a comment saying, I would not. I see no medical reason to. And then we also have another comment. In which instances you could use TPO agonists?
So TPO agonists can be used to prepare patients. Important is to keep in mind that the option of thrombopoietin agonists should be considered in case of elective procedures, not as an acute measure. And we have consistent data about the forms of inherited thrombocytopenia I have showed, but there are always new single reports that these drugs probably function also in other disorder. And it is interesting to know that the safety issues, for example, of the use in pregnancies are not very well clear, but there are reports in patients with inherited thrombocytopenia also in this particular setting, which seems to be effective and safe. One has to start and then check the increase of platelet count and decide how to go on or to change the therapeutical approach.
And I would like to add one aspect to this. If a patient has major trauma or non-planned major surgery, then it might make sense to right away start with the thrombopoietin receptor agonists that in the reconvalescent period where there's an increased bleeding risk, the platelet count then increases and adds to stabilization of hemostasis. But these are individual decisions depending on the case and the case severity.
Thank you so much. Perhaps we have time for one last question. How do you explain the fact that donors under SSRIs are in many blood donation centers, example DRK, BRK, ORK, allowed to donate platelets, or the whole blood is used in pool TC production? Is it the knowledge about the risk not known to all, or am I missing some logic?
These platelets are a little bit impaired in their function, and probably, especially if they end up in a pool platelet concentrate, the overall effect might be minor. But please take into consideration that this webinar was on how to manage patients with inherited platelet disorders. And we tried to indicate different reasons which are not related to the underlying platelet disorder, but which can aggravate the bleeding risk. And often several aspects come together. If you imagine an elderly patient receiving an antidepressant plus a statin plus an antihypertonic drug, and then taking any alternative medicines, they can up in substantial bleeding situations. And those of you who are taking care for these patients should also be aware about these usually neglected reasons and causes to counsel the patient accordingly to avoid the one or the other potential reason which aggravates the bleeding risk. Each of these single aspects are probably of minor biological relevance, but the addition of them, of 3 and 4 different factors together, they can then tip over the hemostatic balance towards bleeding.
Great. Thank you so much for that response. I believe due to time constraints, I think that would be the last question. But I believe one of our coordinators, Dr. Paul Saultier, would like to say a special word.
Yes, thank you, Gavin. We are coming to the end of this webinar series on constitutional thrombocytopenia, and on behalf of the scientific coordinators of the webinar series, I would like to warmly thank Andreas Greinacher, Carlo Zaninetti, and all the previous speakers. I believe and I hope everyone has appreciated the high quality of each of these presentations. I would also like to express my gratitude to Gavin McDonald, Mariangela Pellegrini, Beatrice Gulbis, Pierre Fesneau, and the entire EuroBloodNet team for their support in organizing the webinar series. And as Gavin previously mentioned, all the webinars will soon be available for streaming. So you will be available to watch them again if you wish to, or to recommend this talk to members of your teams. And in collaboration with EuroBloodNet, we already started developing a new webinar series that will be focused on platelet function disorders this time. We will be communicating about this new educational project in the coming months. So with that, thank you all for your participation, and I wish you very happy holidays.
Thanks for the opportunity.
Thank you.